So I wanted to address a couple questions that came up during my clinical. The first question was about peripheral vascular disease. So what does peripheral vascular disease consist of? That's a question to you all.
The flow around your veins and arteries.
Okay, so it has to deal with both the veins and the arteries. So don't get that V confused with venous. So a lot of folks are forgetting that peripheral vascular disease covers both types of vessels, the arterial vessels and the venous vessels, okay? So you have to know about arterial insufficiency, you have to know about venous insufficiency, you have to know about peripheral vascular disease and how it happens. What's the difference between the two? They both present differently. So you need to know signs and symptoms and then how to treat it. So don't, who can actually, if you delegate TED hose to be placed on, what can that unlicensed personnel, LVN, et cetera, do? So I wanted to start with that one. The next thing I want to address is the what questions you have about basic ECGs, because I found that my clinical students were going way into depth. So what are you all's thoughts? Or where are you with the basic ECG?
I was doing some practice questions, and it would describe one like if there's no P wave, but the QRS is irregular or regular. Basically, it would describe it, okay. And then I would have to determine what rhythm it was. And I guess that was kind of getting me because I couldn't visualize it.
Okay. So what I did, I'm going to share my screen. Find the, before I say I'm going to share my screen, let me find what I'm looking for first, then I can share my screen. Hang tight. That took forever. Okay, so there's actually you can find this online, but just to kind of go through all the things of what we covered already. So that way we're all on the same page. All right, now let me go and share screen. Let's try this again. There we go. All right, so can you see the screen? Or can you
yes.
see?
Yes.
All right, so we've talked about the 4 chambers, correct? So this particular document kind of goes through the whole cardiovascular system and basic ECGs, what the pulmonary and systemic circulation, what it does. It even talks about the coronary arteries. So this is what we were referring to, or I was referring to in lecture. So this is your right coronary artery here, and it's going to feed all of this, the right atria, the right ventricle. So it's pretty much the right side of the heart. Then you have the left main coronary, which is behind, it's right underneath the aorta. And so it branches down into the left anterior descending, which basically feeds some of the left atria, but the majority of the front of the heart and the left ventricle. So it's kind of along that septal wall. 4 is the circumflex, which kind of wraps around to the lateral side of the heart and to the back. And so those are your main coronary arteries. So as small as they are, they actually have a lot of, they're very critical is what I'm getting around to. So this kind of goes, this particular document goes into the physiology, what happens, kind of tracing a drop of blood through the heart. So I'm going to skip through that because I just want to get to the whole, how do you read the ECG part? But in order to understand that, it kind of goes back to the stuff that we spoke on prior. So heart rate, we know normal 60 to 100. Stroke volume, it's something that has to be measured, but it's the amount of blood that's being pumped out of the ventricles in one beat. So if you're looking at cardiac output, then that's going to encompass your stroke volume plus your heart rate. And if stroke volume or heart rate goes up, then cardiac output goes up. If heart rate or stroke volume goes down, then cardiac output goes down. But this is normal stroke volume, 60 to 130. So this goes back to the cardiac output. So this is the amount of blood being pumped by the left ventricle in a minute. We usually have between 4 to 8 liters. So you only need one of these two to go up or down, and cardiac output's going to go up or down. Okay, does that make sense?
Yes.
Okay, so here's what preload is the amount of blood or the volume and stretch of the ventricular myocardium at the end of diastole. So that's your preload. It's basically venous return back to the heart. Afterload is what the pressure that the left ventricle must overcome to push the blood out through the aorta. That's what your afterload is. So here's our normal conduction system. What our SA nodes are, which is up here in the right atria. It's our intrinsic heart rate. And it's going to contract not just the right atrium, but also the left atrium. Then that contraction or impulse will gather at the our atrial ventricular node, and this is our gatekeeper. So impulses coming from the SA node are going to come here. This will determine if every impulse the SA node is eliciting is going to actually get through. And in some conditions, it doesn't. Then we have our bundle of His and the Purkinje fibers that kind of wraps around both ventricles left and right. Okay, so you've seen this on the board before. So we have our P wave, it should be rounded upright, our QRS complex, and then our T wave. So as you start to ascend up towards the T is where you kind of have that, where the direction of the S wave changes, then that's where you're going to start going into the T wave. But P wave is atrial repolarization or depolarization.
Depolarization.
Depolarization or contraction. QRS is the ventricular depolarization. But during this phase, the atria is also repolarizing. And then we've already talked about the T wave is when the ventricles do what?
The ventricles repolarize.
So this is when the ventricles are repolarizing. And then we have this QT interval that we talked about during fluid and electrolyte. So this just kind of gives you a graphical representation. So we're going to slide on down to the different waveforms. And this actually has modules. So this is what an EKG strip looks like. And we talked about this in class on Tuesday, this isoelectric line. So pretty much the P wave and the T wave should pretty much fall along that process. Our PR interval should be from 0.12 to 0.20, which is basically one of these square boxes. And it's going to, the next couple slides will show you that. Our QRS complex should be less than 0.12. So when I'm talking small boxes versus big boxes, these darker bolded lines that's one big box. But in one big box, you have 1, 2, 3, 4, 5 little boxes. And each of these 5 little boxes down here, as you can see here, they're representative. One box is to equals 0.04 seconds. Okay, so that's how you're measuring that P wave. and the QRS complex. You're using these little boxes in between. So one large square is 0.2 seconds, and one little box is 0.04 seconds. So these are the 5 steps you should use to determine what your ECG rhythm is. First thing you're going to do is calculate the heart rate. And remember, we said that the entire heartbeat must be on that page in order for it to be counted as a full beat, right?
Yes.
Okay, just checking. So we count the number of R waves, and we're going to multiply it times 10. That's going to give us our heart rate. Then we need to look at if it's regular, and when we get to some of the other slides, it's going to outline how you determine whether it's regular. There should be a P wave in front of every QRS. So that's the next thing. So when you see a QRS before it, there should be a P wave. And that P wave should be upright, meaning kind of elevated like a mound. Then you have your PR interval that should be within normal limits, which is basically no greater than 0.20. And then our QRS complex should be less than 0.12. So that's your guideline for interpreting. We're only doing basic rhythms. So we're not going to complicate the issue, okay? So we're just going to count the number of QRS complexes that happens in a 6-second interval, and then we're going to multiply it by 10. There are other methods that are more accurate than what we're doing, but we're just doing basic ECG, okay? So we're not looking at what do you do to treat it. We're not looking at that. So for example, here is a 6-second strip. And in this 6-second strip, if you were to measure this R to this R, they would be equal all the way through. And how would you do it? You could take a piece of paper and line it up below these little points, make a hash mark and a hash mark, and then take that paper and follow it all the way to the next one. Now you are allowed to be off by one small box, left or right, and it will still be normal. And I hope that makes sense. But here, this is regular. Even if you measure these arrow to this arrow and then measure to this one, to this one, to this one, to this one, it would still be regular. So this would be considered regular, okay? I'm going to skip over these charts because that's not what we're trying to do here. So for something to be considered irregular, then the interval between the R waves is not equal, or it's not consistent. So that means that some of those R waves will come early and some of them will come late. Okay, so this is another way of counting it using the little small boxes, but we're going to move on because I don't want to. Some of you are so stressed on this one piece. I just don't want you to get so far stressed you go in the opposite direction. Okay, so a P wave is produced when the left and right atria depolarize. So here, this is a P wave, this is a P wave, this is a P wave, and overall they look the same. So we don't have some that are super pointed or some that are super rounded. They pretty much have an equal pattern. So that's what I mean by P wave in front of every QRS. So when you're looking at the P wave, these are questions you're asking. Are they present? Are they occurring regularly? Is there one in front of every QRS complex? Are they smooth, rounded, and upright in appearance, or are they inverted? And basically, if it was inverted, instead of being rounded, then it would be like a spoon. As if you hold a spoon, then the rounded portion would be below the isoelectric line. So do they all look the same? PR interval is just basically a measurement, but everything of what I've been asking you is here about the atrial and ventricular depolarization and repolarization. So this is how you would measure what the PR interval would be. So from the beginning of the P wave and then right before it hits the Q, that's your PR interval. And then you would start your Q here to about right here for the QRS complex, and that's coming up shortly. So this is just basically how to measure. So they're asking, is this less than 0.12 seconds or is it within normal limits? All right, so the QRS complex is the first negative or downward deflection of the complex. The R wave is your first upward or positive deflection. So your Q wave originally should go down first, then it should go up and then go back down, okay? So it shouldn't be any more or any bigger than 3 boxes and as little as 1.5. So if it's 1.5, that'd be 0.6 seconds. So we measured from the beginning of the P to right before the Q as our PR interval, and then we start here at the Q, right midway between the S as the slope direction changes in here. And this should be less than, between 1.5 and 3 small square boxes, not the big ones, the itty bitty ones. So again, same questions. Is it greater than 0.12 seconds? Is it less than 0.06 seconds? You know, what does the appearance look like? And when you get the 4th semester, you'll start seeing different representations of the QRS complex, but that's not for 2nd semester. We're just trying to keep everything basic. So here's a strip. So 1, 2, 3, 4, 5, 6, 7, 8, 9. Would that be correct? Because
Yes.
I don't have this whole beat here. So I would go with 90. This is going with something altogether different because they're measuring these little boxes, so they're getting a lot more accurate, but this looks faster than 79, just on an eyeball. Okay, is it regular? Well, from here to here looks regular, from here to here looks regular. From these R waves, it all looks regular. I don't see any extra beats in here, and I don't see any delays where it's like the beats happening here. Okay, there is a P wave in front of every QRS. P wave is within normal limits, and so is the QRS. So that would be considered normal sinus rhythm. If there's any abnormalities, like a premature beat of any kind, then that's not normal sinus rhythm. It becomes sinus rhythm, and then you identify the abnormality. Does that make sense?
Yes.
Okay. So the rest of this, I'm going to skip through, but this is just kind of shown, you know, we go back to fluid and electrolytes and how the T wave, you know, can tell you about hypokalemia. That's kind of where it's getting at this point. And your U waves, or hyperkalemia. So your T wave will be hyperkalemia. Your U wave would be hypokalemia. So let me just roll the slide back so you can see that this is really addressing the U wave, which is this here, because you would only see it if you have hypokalemia. And then the slide before that is the T wave. And the T wave, if it was tall and peaked, that would be hyperkalemia. All right, so I'm going to slide on down. A lot of this could be patient movement. You know, the leads may not be on really well, may not be grounded really well, but this is called artifact. So it's not, it doesn't mean that the patient has atrial fib. This means that the patient's moving around, or if there's some other abnormality. So check your equipment. Well, check your patient too. All right, so the only three that I'm going to talk about on this slide is going to be normal sinus rhythm, sinus Brady, and sinus tach. You do not need to pay attention to anything else, and I'm not going to even cover it, but it was there listed as an objective. So here, as we spoke on already, I have a P wave. It's in front of every QRS complex, right? And it's within 60 to 100 beats per minute. My PRI or PR interval is within normal limits. My QRS is within normal limits. So this would just be a normal sinus rhythm. Steps. Skip this one. We just want to know, is it regular? That's what we're really asking. Is it regular? If you go back up, it's regular from here to here to here to here to here, all the way through the strip. It's regular. We have no early or late beats. Okay? So we don't need to do anything. Someone asked, do you need to know medications? No, you don't need to know medications. That's for fourth semester. Sinus bradycardia, the heart rate's less than 60. So this is an example of sinus bradycardia. Now, in this particular strip, remember your Q wave should be the first downward deflection. This is actually an upward deflection. So this is another representation of how a QRS complex can look. So it doesn't mean that it's wrong. It just means that it's just a different way of how it's tracing on the ECG. Okay. So here's our P wave, but it's actually a little bit extended. And as I explained to my clinical students, the slower your heart rate, because this one is 40. So the slower your heart rate, the longer your PRI. Just so if you see it, don't freak out. But this will be sinus Brady. It won't be normal sinus Brady. It's just plain sinus bradycardia. In order for it to be normal, it must be between 60 and 100 beats per minute. These are causes. You do not need to know this. But if you are wanting to know when would this situation arise, these are all the different causes. And this is how the patient would present. But this is fourth semester stuff. I'm going to skip over that because this is treatment and we're not going to, we're just wanting you to identify. We're not trying to treat anything. All right, sinus tachycardia. And that's 6-second strip. And how do we know it's 6 seconds? Well, here's our 0 mark, here's our 3-second mark, and here's our 6-second mark at the bottom. Now, usually this white bar is at the top. So just FYI. But it can be either way and it's still A-okay. We have a P wave in front of every QRS. It's rounded, it's upright, and then we have it's regular. The distance from this R to this R is the same, from this R to this R is the same, etc. On this strip, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 12 R waves, which means the heart rate's 120 beats. QRS is narrow, less than 1.2 or 0.12. So we're good. But it wouldn't be normal sinus tachycardia. It would just be sinus tachycardia. The only time normal can be used is if the heart rate's between 60 and 100. All right. These are causes for somebody to become tachycardic. How they would present, you don't need to know it. Don't write it down. Don't memorize it. It's not on this test. But just if you wanted to know for your own reference. This is how it would be treated. And depending on the situation, will determine how they're going to manage it. I'm skipping over sinus arrhythmia and sinus pause and arrest and all of that. So I'm skipping those. I'm going to go on to the next piece. So don't learn those. Don't waste your time getting stuck on that. There's 5,000 other things you could be doing than that. The only thing I'm going to show you in here is the atrial fibrillation as it relates to heart failure? But just looking at this, does this strip look regular?
No.
Okay, so this would be irregularity. And there's not a P wave in front of every QRS. It's not discernible or distinguishable. So this would be an example of atrial fib. It's irregularly irregular.
That's how I give me back.
Okay. So we're gonna move on. We're not gonna, these are some reasons why. Here's heart failure right in here. Hypertension, that could be a reason why the person has atrial fibrillation. There's other causes, but that's usually the primary. Group 2 are the primary. Okay, so you may supraventricular tachycardia. That's just where the heart rate's greater than 150. And it's kind of hard to see the P wave because it's embedded into part of the T wave. Okay. So I don't know, you know, what's going on, but it's more than 150 beats. So that can happen. It just means it's above the ventricles. It's definitely coming out of the SA node though. So that for all your monster drinkers and caffeine drinkers, that would be what your heart would be doing. And that can go all the way up to 220 beats per minute. So any stimulants, stress, hypokalemia, those things can cause it. And usually the person will be short of breath, has some chest tightness and palpitations. Keep in mind, if you do, what are vagal maneuvers? Anybody know?
Is that where you would try and like bear down to reset your heart rate?
Right, so you can bear down like you're gonna take a poo or hold your breath. Some people massage the carotid artery. Now, you notice I didn't go plural. I said artery because you can't massage them both at the same time. You'll pass out. So don't do that ever. But those would be vagal maneuvers, kind of bearing down. But that's a way of treating it outside of medicines. Don't need to know for the test. That's just an FYI. So, you know, don't say, oh my God, I didn't study that one. It's not a big deal. All right, so skipping that. All right, ventricular rhythms. These are your lethal rhythms. So this is when the SA node and the AV junctional tissue do not generate an impulse. Then the ventricles will now start to pace. That's why there are no P waves. Okay. All right. So with ventricular rhythms, the QRS complexes are wide. So that means they're going to be greater than 0.12 seconds, and they're going to be bizarre or abnormal in appearance. They're lethal rhythms. The only lethal rhythm we're going to talk about are going to be these two right here. Ventricular tachycardia and ventricular fibrillation. Oh, and this one here. This is not really a ventricular rhythm. It's just no rhythm at all. Okay? So the heart's not even moving. So I'm going to skip through all the other business when we start talking about the stuff that we don't need to know. These are ectopic beats or premature beats. So would this be considered regular?
No.
Not regular.
It's not regular. This is irregular, and what's making it irregular are these premature ventricular contractions. This up here is regular from here to here, from these 4 beats and this beat here, but this here makes the whole beat irregular, okay? With that being said, this would not be a normal sinus rhythm. This would be sinus rhythm with PVCs. So that's how that would be termed. And you can have atrial contractions like that. You can have junctional contractions, but there's several different types. in this particular slide, just to kind of show you the different morphologies of the ventricular rhythms. So this is a PVC here, and then here's a PVC here. So VTach, when we get to it, it can look different. These are two PVCs together. These are couplets. But when you get three or more of these PVCs in a row, and what that means, if this is a couplet, if I was saying there had to be three or more, it would be 1, 2, 3 of these PVCs in a row. Then that person's going to have that's considered a run of VTach, and they run the risk of developing ventricular tachycardia very quickly. I'm going to skip over that. Skip over that. I'm not going to talk about any of these. And that's why I said we're just scratching the surface. There are a lot more ECG rhythms. So we just need you to know the basics. Not all the other 5,000 ones that exist. All right, so here's ventricular tachycardia. So here is one example of what ventricular tachycardia would look like. And this is more upright with here's your upright QRS here, but it can also look like this down low. So these are the exact same, meaning the exact same rhythm, but their ECG tracings differ. This is a lethal rhythm. Now, if you have a patient that's in ventricular tachycardia, which is right here on the screen, you always have to check a pulse. The reason being is because the person can have ventricular tachycardia and have a pulse, which is known as perfusing VT. If we don't have a pulse, then we're going to start CPR, okay? So usually if you have a patient that's in cardiac arrest, if you get them and they're in ventricular tachycardia, you have a chance. If you get them and they have already deteriorated to ventricular fibrillation, you have a chance, but man, if you don't move quick and get things taken care of, they're going to go asystole. So we're going to scroll on down. So all of these are different causes: electrolyte imbalances, specifically potassium, digitalis toxicity, all of those things, prolonged QT with those other electrolyte imbalances that we talked about in food and electrolytes. All right, here's ventricular fibrillation. Now, does this look like it's regular?
No.
No.
No. So the ventricular tachycardia, it's always going to be regular. When you see this, that's irregular. What's down below is what they call fine VFib. So fine ventricular fibrillation. What's up at the top is coarse ventricular fibrillation. So a lot of times when you have a fine VFib, it can almost look like an asystole. And if it looks like that's why we make sure we check in 2 leads if we think we have asystole. Okay? But this means, this person is close to death. They have 1 foot in the ground. VTach, they laying on the ground. VFib, 1 foot's already in. So all of these, AMI, acute myocardial infarction, untreated ventricular tachycardia, myocardial ischemia, all of those can lead to ventricular fibrillation. I'm not going to talk about that. I'm going to move on. I want to get down to asystole. Really. So here, nothing's moving. There's nothing atrially. There's nothing ventricularly. The heart has literally stopped. 2 feet are in the ground, basically, is where we are with that. Does that make sense?
Yes.
Okay. So keep it simple. We're not looking for signs and symptoms. We're not looking for, causes. We're not looking for how to treat it. We just need you to, look at the strip, do your measurements, and say, this is blah, blah, blah. You know, if that's whatever it's asking you. So you should be able to identify the rhythms that I spoke about. Sinus rhythm, sinus Brady, sinus tach, ventricular tachycardia, ventricular fibrillation, and asystole. Asystole, everybody gets, it's a flat line. It's just a straight line. It's the other ones that seem to give folks trouble. So, any additional questions regarding ECG that I can clear up at this time?
So do we need to know ventricular tachycardia and all that? Ventricular tachycardia, what's it called? I can't be saying this. Supraventricular tachycardia and all that.
Okay. The 5 you need to concern yourself with, because we're just doing basics. Sinus rhythm, sinus Brady, sinus tachycardia, ventricular tachycardia, ventricular fibrillation, and asystole. Those are your basic ECGs. You need to know that your 2 ventricular rhythms and your asystole are considered lethal rhythms. Those are the rhythms that people die out on. So when I said that, you know, here you lay on the ground in V-tach, V-fib, you have 1 foot in the ground, asystole, both feet are in the ground, and you're sliding in, the rest of the body sliding in. That means the person's dying. Okay, and when it's a flat line, you have no heart pumping action, you have no heart electrical activity, so the heart's technically dead.
Okay.
Does that make sense?
Yes, ma'am.
Okay. So what I was trying to prevent you guys from doing is creating more extra work. I had one clinical student who was looking at causes and how do you treat it. That's not what, we just need you to understand what it is. How do you calculate it? How do you know if it's regular, irregular? What's your P wave measurement, your PRI? Is it normal? Is your QRS normal? So that's all you're really basically doing is basic ECG. We're not covering, and as you can see, there are so many other rhythms, and then there's some rhythms that we still did not even, that's not even in this slide. So I just found something to kind of bring home all of the things that we talked about. And you can go online and look at stuff, but do not overwhelm yourself with things that, you don't need to stress yourself over. And that's the reason why I'm addressing it, because I don't want you all getting so overwhelmed with the whole ECG thing.
Okay, ma'am. Thank you, ma'am.
So it's really easy to do, but that's not what that's not what I'm envisioning when I'm talking about the ECGs. Okay.
Okay.
So I covered the PVD question, which is peripheral vascular. You need to know venous and arterial, and also their insufficiencies, venous and arterial. Pardon me. And I've covered the ECG because that seemed to be a big sticking point related to that. I'm going to stop sharing screen. And I'm going to now talk about neurogenic bladder. So before I go into that, what questions do you all have about neurogenic bladder? Has anyone even started looking at it? I hope so, because the test is Monday. All right.
So our exemplar was basically the spastic neurogenic bladder, right? Mm-hmm. We didn't need to dive into the flaccid, the other side, right?
I think in your book it covers both.
Yeah.
So we can talk about the difference between flaccid and spastic. basically spastic is spasming, flaccid is flat. So it's a flat bladder. So what is neurogenic bladder? Who wants to tell me what neurogenic bladder is?
Problems with the nervous system controlling the bladder.
So it's a condition that causes problems with bladder control. And the causes of that would be some type of central nervous system disorder or injury that the person may have had, okay, related to the bladder, okay? So there's dysfunction of the bladder. There's an interruption of the normal bladder function and how it works. It can involve hyperreflexia, which is basically the spastic bladder. Placidity, which is basically a hypotonic or atonic bladder. Or it can be incoordination of the bladder contractions with the sphincter relaxation. So there's a dysfunction there. How does it happen? Usually the patient has some type of injury or lesion to right around T12. So it's at or above T12. And that's going to cause a person to have spastic bladder. The lower neuron lesion, so if it's at or below S4, that person's going to have a flaccid bladder. So that individual will have more residual urinary retention. They'll have a decrease in their pressure inside the bladder. The bladder doesn't empty spontaneously or completely. So that would be in a flaccid bladder. In a spastic bladder, they have a lot of contractions. They have a lot of pressure inside when they void or when they pee. And that bladder wall can actually become hypertrophied. What does hypertrophy mean? Bigger? Like a
Smaller, like this.
kind of thicker
Mm-hmm.
or enlarged. So there they have a lot of sphincter spasms. So that's the difference between spastic and flaccid. Now, when you're talking about all these lesions are abnormalities. And you can have a neurogenic bladder from a stroke, from a brain tumor. Parkinson's disease are some examples. From a spinal cord, you can have spinal cord injury. We talked about T12. And then we also had injury at or below S4 for flaccid, okay? And there's some other reasons why, like a herniated disc. So if you have a herniated disc, then that can cause a person to end up with neurogenic bladder. Anything else you can think of related to neurogenic bladder as far as risk factors? So we have spinal cord disease or injury, trauma, stroke, so cerebral disorders. If they have any type of heavy metal toxicity. So there's several different reasons why. Pelvic surgery, they nicked the wrong thing. Okay. Complications from a neurogenic bladder, they're gonna have urinary retention. So there'll be urine still left in the bladder. They can end up with urinary tract infections. They can end up with renal failure. And they can also have incontinence, which means they pee on their own or pee on themselves. When you're assessing them, then they'll complain of frequent UTIs, involuntary or frequent scanty urine. So they don't, the bladder doesn't feel full, but they're scantily going. Or they can have incontinence, which is they're peeing on themselves. Then that could be due to diminished sphincter tone or urinary dribbling. So it just kind of dribbles out. So your findings, stress incontinence, urinary retention. They may have hypertension, bradycardia, spontaneous spasms caused by voiding of the arms and the legs, a greatly distended bladder without them feeling that the bladder is full because they've lost that nerve sensory aspect, so that the sensory impairment has been compromised. They have the urge to urinate. How are we going to, determine it? But outside of history, we're going to get a urine culture, which may reveal that they have a UTI. Our BUN and creatinine levels, they're going to be compromised. But they need to have some type of imaging, like an ultrasound of the kidneys, or a urethrogram or urethograph, something to look at the ureters and the urethra. They may do a cystogram or a cystoscopy that kind of looks at, do they have any lesions in the bladder themselves? So what type of nutritional things should they avoid if you have a neurogenic bladder?
Things that make them urinate.
Things that's going to make them urinate. So stimulants, spicy foods, citrus foods, chocolates, they should avoid. Avoid excessive intake of fluid, but they still need to drink enough fluid to be hydrated. No caffeinated or carbonated drinks, and no artificial sweeteners. All of those will definitely complicate the issue. Some things that they can do without medications would be pelvic exercises. So those Kegel exercises, ladies can do that to help with, vaginal weight training. Some may do like an electrical stimulation therapy to help. What type of medications, what antispasmodics can we give them?
So Bethanacol, or I don't know if I'm saying that right.
Baclofen.
I didn't hear it. Say that again.
Baclofen.
Are you talking about Bentyl?
Baclofen. Baclofen.
Baclofen?
Mm-hmm.
Okay. Isn't baclofen like a pain med?
It's an antispasmodic drug, I believe.
Okay.
It's used to decrease spasticity of the pelvic floor muscles.
Okay. Any others besides that one?
Uricoline.
Okay, what's uricoline?
It helps stimulate the contraction of the detrusor muscle, or the detrusor sphincter.
Okay. And what others do they have listed?
What is Detropan for?
Carrying the conceal up without a license, when they want to call him.
Oh, I'm not sure if she's answering your question or not, but repeat that again, please, Marky.
I think that was Corin.
Oh, Corin, can you repeat what you said to the whole class can hear?
Is it Detropan? What is that for? Is that for the bladder as well?
I'm not sure about Detropan. Hold on before I say no. Oh, Ditropan. That is an antispasmodic. I thought you said Detro, but it's DITRO. That's okay. And it may have been how I heard it, but DITROPAN. That is an antispasmodic. So that is true. Vesicare, that's another one.
Doxazocin.
A who?
Doxazocin, Cardura.
Bentyl, I know for sure. That's an anticholinergic. There's Detrol. There's Sanctura. There's Tofranil, Elavil. They use some of those to help with bladder issues. All of those would be applicable.
Did we already say sulfasalazines? I don't know how to say it. Oxybutynin.
Yeah, that's the Ditropan. The
Oh, okay.
the oxybutynin chloride.
Then I have here Neurobandol
Okay,
to help reduce spastic bladder.
right. So we have several antispasmatics is what I'm saying to help with that. So outside of nutrition, medications, what else can we tell our patients to do? Or
What about like INO, straight cats?
okay, so we can catheterize patients, okay? And they should perform, the catheter care, so we need to teach them how to do that. They need to be on a bladder training program. When I say bladder training, what do I mean?
Go into
Like
the
Kegel
bathroom
exercise?
every 3 to 4 hours.
Okay, so every 3 to 4 hours, it's basically like potty training. So every 3 to 4 hours, then they should be emptying their bladder, with a straight cath. And a straight cath is just a Foley. It's not the ones that have a urimeter drainage bag. It's just basically in and out, like it says. It's not meant to stay in. So they need to set up specific times, and the times need to be consistent to empty the bladder. So you can't go 2 hours and then go 3 hours, then go 4 hours. So it needs to be between 3 and 4 hours. So you pick the 3 mark, then every 3 hours, they need to empty the bladder. So that's the bladder training for neurogenic bladder, okay? If you, we can teach patients to self-catheterize, again, consistency, every 3 to 4 hours. So, don't feel overwhelmed. I mean, yeah, neurogenic bladder is significant, but it can be trainable. With a flaccid bladder, since they can retain urine, the one thing you don't want to do is have them over distend the bladder. So that's the other reason why we have them on those consistency plans to eliminate. So we don't want their bladder to become over distended. That's not the same for the spastic bladder. Okay, spastic bladder, we're trying to decrease the spasms. So when you have patients that have neurogenic bladder, we want to teach them about self-catheterization, being on a bladder training plan, must be consistent and it has to have a regular schedule and be consistent every 3 to 4 hours. And then for your flaccid bladder, we just don't want them to over distend the bladder. So that's the reason why we're doing the emptying, okay? Questions? Somebody is having a good time.
No questions. I have just a comment. We're gonna do, I guess, the skincare because of the frequent urine. Some sort of cream barrier.
Absolutely. So the other thing you want to do is keep the area nice, clean, and dry. And especially if the patient's dribbling, you don't want to, you're talking about Janie, don't make sure the skin's good so they don't have skin breakdown.
Yes.
Okay. Anxiety, I would have anxiety if I knew that at any point I could pee on myself. So, try to maintain privacy and things like that. So those things will need to be addressed. Nobody wants to wear the little Depend diapers and things like that. I mean, they're actually churching them up on TV now like it's the next best thing to sliced bread. Oh, it has designs. I'm like, okay. Encourage the exercises, like the pelvic floor exercises. So that would be another thing to do, and just to avoid things that can make them pee on a regular basis, like the stimulants and spicy foods and caffeinated drinks and things of that nature. Does that make sense?
Yes.
Okay. So any questions about neurogenic bladder or any other material that we've covered this go round? Who can tell me the three eyes? What are the three eyes? This is a perfusion one. More specifically related to angina, what are the three eyes?
Like, are you talking about infarction, ischemia?
Ischemia, injury, and infarct.
Okay.
So when you have a blocked artery, or that can happen anywhere. So anytime there's a blockage in the vessel, the first thing that's going to happen is ischemia, because you can't get blood distal past the blockage or the clot formation. If that isn't corrected, then the person's going to develop injury. The tissues, the surrounding cells and tissues will become injured, and then the surrounding tissues will begin to die. They will for sure die distally because they don't have no blood flow. So ischemia, injury, infarct. That's how the heart tissue works, and it doesn't rejuvenate. Okay?
What are diagnostic tests we need to know?
For which material? Because there's tons.
That's the problem. There are tons.
Okay. So what I would do is I would take each of what you should have been doing is studying all these in little pieces. So that way you can tie them together. If it depends on the disease condition, that's going to determine whether or not, what diagnostic studies you can do. If you have somebody with acute diverticulitis, the two diagnostic studies you're not going to do is a barium enema and a colonoscopy. We don't want to set them up for perforation. So if it's not acute, then those things would be A-okay to do. Does that make sense? So depending on your disease or your exemplar, that's going to determine what diagnostic studies would be appropriate. But you got to know about your you have to know about your myocardial bands, the CK&Bs. That's what that is. The CK and MB means myocardial bands. Troponin I, troponin T, your myoglobin. Those are your lab values that you would get for if you're suspecting somebody is having a heart attack, right? So if you're worried about, heart failure, then your B as in boy, N as in Nancy, P, the BNP value, you want to get that. And you need to know that value range. How do you know the person's not in heart failure? How do you know what's mild, what's moderate, what's severe? So the higher the number, the BNP, the more severe the heart failure. What's the difference between left heart failure and right heart failure? So left
symptoms,
pulmonary, right, you have liver fluid collecting in the abdominal cavity. Then you have the sacral edema, dependent edema, splenomegaly. So that's completely different. Usually right heart failure is caused by left heart failure, but you can have them both happen differently or independently. Okay? What does the ejection fraction mean if it's less than 40? Do you have an increase in tissue perfusion or a decrease in tissue perfusion? What does that mean?
Decrease.
It's going to be decreased because the person has what disease condition?
heart failure.
They have heart failure. So we're not going to be getting blood out to the tissues, because in heart failure, the blood fails to move blood forward as a forward pump. Okay. So, how do you recognize signs and symptoms of heart failure? Jugular venous distension, dependent edema, rails on auscultation, those would be your more consistent ones. Engorged neck veins, that's the same thing. Neck vein distension, that's the same thing as JVD. If it's right heart failure, you can have right upper quadrant tenderness. Why? Why would you have right upper quadrant tenderness?
Because that's where fluid starts collecting. Your liver is swollen.
It's because your liver's swollen. That's the reason why you have that right upper quadrant tenderness. Okay? what medicines, if you have left heart failure, would be appropriate to give?
An ACE inhibitor.
If you have left heart failure, we have a collection of fluid. So how are we going to decrease that fluid?
Oh, so a diuretic.
Diuretics.
So we're going to give them a diuretic. So how do you assess the effectiveness of the diuretic? Because
The crackles in the lungs.
you're
the
going to
absent.
assess lungs, because they should have a decrease in the rails or crackles in the lungs. That's how you assess that. Okay. Patients that have heart failure, sometimes they're on an ACE inhibitor, sometimes they're on a cardiac glycoside. It depends, you know, what their management is, but it's lifelong management. It's not like you have it today and you don't have it tomorrow. You have it all time, like hypertension. You don't have it today and not have it tomorrow. It's lifelong medication management. Don't forget about your mitral valve prolapse. You know, what's the causes of mitral valve prolapse? You know, should you be drinking alcohol and having caffeinated beverages? Absolutely not. You know, where can you auscultate the mitral valve? Remember I told you about that? TPMA. So second intercostal space, right, second intercostal space, left, and right along the left sternal border. I'm talking about location before you auscultate. So it's TPMA. But if you're going to auscultate them, the direction of which valve you get to first, before I'm getting ahead of myself. If you're looking at where it is in the heart, the first one that comes is T, tricuspid. The next one as blood goes through is pulmonic. Then it comes back to mitral. Then it comes back out to aorta. That's TPMA. If I'm going to auscultate, then that would be ape to man, or APTM. Does that make sense? So how it happens in the body is TPMA. How you auscultate it on assessment is APTM. So my M would be fifth intercostal space midclavicular. So if I'm going to auscultate my aortic valve, then I'm going to listen to the second intercostal space, right sternal border. If I'm listening for the pulmonic, I'm going to listen directly second intercostal space, left sternal border. If I'm going to auscultate the tricuspid valve, then I'm going to listen fourth intercostal space to the lower portion of the left sternal border. And if I'm going to auscultate for my mitral valve, it's going to be midclavicular, fifth intercostal space. Does that make sense? The midclavicular line, so halfway through the clavicle is mid. So if this is my clavicle up here, so here's my clavicle, then I'm going to go the fifth intercostal space halfway through. So while I won't measure over here, I'm going to measure right down the boob line, okay, or nipple line, however you want to put it. Don't forget about your preeclampsia, eclampsia stuff, pregnancy-induced hypertension, magnesium, things you would be looking for, you know, as far as, you know, deep tingling reflexes and things of that nature. So review that information. You know, side effects related to the magnesium. What's the antidote for magnesium? We learned that last.
Calcium gluconate.
Right, that was on the last test. So calcium gluconate. You know, what kind of happens when you have, you know, PVD, how you treat it, how do you treat, you know, arterial clots.
So is PVD and PAD, are they the same? Because they seem the same when I look them up.
Nope, nope, nope. I had that was the first thing I said when I opened up the Zoom session. PVD is peripheral vascular disease. Under peripheral vascular disease, you have peripheral venous and peripheral arterial. So you have a venous and an arterial side. It's almost like COPD. So COPD is the umbrella company, so to speak. But underneath COPD, you have two conditions.
Bronchitis and emphysema.
Chronic bronchitis and emphysema. This works the exact same way.
Okay.
PVD, the V is vascular.
Okay.
And then under that, under vascular, you have two types of vessels, arterial vessels and venous vessels. So don't get them confused.
Okay.
Make sense?
Gotcha.
Okay. So how do you know if your heart failure patient is in trouble? How much weight gain should they have or should they not have?
2 lbs, 2 pounds.
So, you know, if they have 3 to 5 pounds in a week, that's a problem. If they gain 3 pounds in 2 days, that's a problem. Okay. So they're trying to keep that extra fluid off. Can we put heat on a patient that has, you know, what is the treatment for a patient with PVD?
At stockings.
So TED hose or the compression socks or stockings. Okay, what else?
Make sure no infection.
So no ulcers, you know, monitor the legs, no abrasions, no lesions. What else?
Elevate the legs.
Elevate.
Okay, elevate the legs. Can you put heat on the feet? Can you do that?
No. No heat, no massages, no heat.
Okay. What about, can you do that for PAD? Can you put heat on the feet for PAD?
No.
No, because there's already decreased circulation.
But heat actually increases circulation. So I don't know. I'll say yes though, but I don't know.
Nope, because if it's decreased circulation, how do you know how hot it is or how cold? If it's
You won't have the neurosensory ability to figure out when it's too hot.
right. So, you know, we don't put no heat on folk.
Okay.
Okay. Let's see. What if you had a patient that give me some signs and symptoms of PAD. How do you know someone has PAD?
Their extremities will be cyanotic,
Okay.
cool to the touch.
Okay.
Their pulse might be diminished or absent.
Okay.
May have round, smooth.
They have what?
Sores.
I didn't. Sores?
Yes, round,
Okay.
smooth sores.
Okay. Yep.
And black eschar. It's like I don't really know how to describe it. I just read it. Black eschar.
Oh, okay. Like I know what you're talking about. It's like dead tissue or burnt tissue, so to speak. Okay.
Their ulcers are very painful, and they're lateral, lower leg, the toes and the heels. They're small but deep and circular in shape and necrotic.
Okay.
And they're not. There's no edema.
Okay. Which one of them get intermittent claudication? So that's basically pain in the calves when they're walking.
Arterial.
Okay. So that would be normal, and you would expect their blood pressure to be high or low.
High.
You would expect it to be high is correct, because when it's high, vessels are constricted, right? So that means you're not going to get blood flow distally, which is going to now, you know, they're going to have pain, etc. So just, you know, things to kind of keep in mind is, you know, what things happen normally in a disease process, and then what are your abnormals. So if you have high blood pressure, should you have chest pain? And I said should, not could. If you have high blood pressure, should you have chest pain?
No.
No.
But if you do, what's the concern here?
Infraction.
Infarction. Yeah, an infraction is what you get when the cops pull you over for speeding.
Sorry, you know what I'm trying to say.
I know. But you know what? A lot of people get infarction and infraction mixed up. So that's why when I tell them an infraction is what you get when the cops pull you over for speed. An infarction is what you get when you don't have any blood flow. But if you have high blood pressure and you start having chest pain, you can either be having a heart attack or heart failure. That's not normal. Okay. not normal. And I don't know if you all have watched the news lately, but they've come out with newer parameters for high blood pressure again. Okay. Let's see. What is your concern with statin medications?
Their liver function.
Okay, besides liver.
Muscle pain.
Muscle pain, muscle atrophy, muscle.
Rhabdomyolysis.
I'm sorry, what was that, Janie?
Rhabdomyolysis.
Right, rhabdomyolysis, but that's because of the breakdown of the muscle related to the statin. So that's why if the person has, complains of leg pain, then, you want to definitely, have them be seen. That they don't pass that over. Oh, no, this is normal. No, we don't want their muscles breaking down. Don't forget about, all of the lab values associated with coronary artery disease. I've already talked about those as well. Knowing your modifiable and non-modifiable risk factors. Okay. Things that can cause you to have impaired perfusion. Like we talked about high blood pressure, nicotine, the cigarette smoke makes the vessel smaller, right? Diabetes, they make the vessel sticky, but it decreases the blood flow. Obesity, those are things that can impair your perfusion. And there are others, but just, go back and look at what would be applicable. Okay. Do we do bilateral carotid massages?
No.
Absolutely not. And please do not try it on yourself. Do not. What is the hallmark sign of MVP, which is not most valuable player, but mitral valve prolapse?
Syncope.
The click mild
Palpitations.
The mid-systolic click. And they could have a late systolic murmur. So remember we talked about that when we did mitral valve prolapse in class? Nobody remembers?
Yes.
Oh, okay. I was just wondering. If you have a patient that has diverticulitis and they start having a bunch of pain, is that normal?
No.
Okay, so yeah, if diverticulitis, if the belly starts to get hard or distended or anything like that, that maybe it's a perforation going on, or maybe peritonitis. So just know your signs and symptoms related to the disease condition. I'll get it out in just a sec. What are the different types of fistulas that I spoke about for Crohn's?
Like between intestines or other organs or the skin or anal fistulas.
Type.
Anal.
The
Bladder. So to the intestines, to the bladder. So if all of a sudden you start getting some, something that look like poo, is stinky, then you should be thinking it's a fistula. Okay. Nutrition wise, what do we want to talk to them about?
For like maintaining.
For Crohn's.
For Crohn's.
If you're going to have fruit, have it canned.
Say that again.
If you're going to have fruit, have it canned or without the skin or boiled.
Okay, what about meats or protein or carbs or calories? Are we concerned with any of those?
Yeah, high calorie.
Okay.
And high protein.
High
protein.
Okay, I'm coming right now. Come on. Come on. Let's do it right now. Come on.
I'm done. Come on. So high calories, high protein. How about the B vitamins? What about those?
We're going to give them shots of that and iron because they have malabsorption, so they're probably not going to tolerate PO.
Okay. So definitely some B vitamins, B12, folic acid. So those would be some good things to also incorporate, right? What is a paralytic ileus? Define that.
Where there's been like abdominal surgeries or some reason why the patient's gone under sedation and the bowel's not waking up afterwards, and
Okay.
basically the intestines have died, or a portion of the intestines have died.
Well, basically, it stopped. So they have paralysis of peristalsis is what a paralytic ileus is. And that's the beginning form of a bowel obstruction. So when you have a paralytic ileus, that means nothing's contracting through. There's no contraction. That patient will more than likely get a nasal gastric tube, and we need to make sure that the patency of that tube is maintained. If we don't treat a paralytic ileus, it will become a bowel obstruction. If we don't treat a bowel obstruction, what's going to happen?
Peritonitis and infection.
Exactly. It's going to rupture though.
Mm-hmm.
But they can't end up with peritonitis. It's going to rupture because all that pressure is just going to go poof, and that's going to be that. Okay. Are there any electrolyte abnormalities that we should be concerned with Crohn's?
Since you're asking, that means yes.
Okay, which one?
Because the patient may have diarrhea, so they may be excreting.
What's going to be the one we're going to be more concerned about?
Good question.
Say that again, Corin.
Is it potassium?
It's potassium. She goes, if you're asking, then it must be yes. I love it. I love it. Okay.
So they may fall into hypokalemia because of the diarrhea.
Correct. And then if you want to go and trace that back to acid base imbalance, what would that be?
Metabolic alkalosis.
Alkalosis, yeah.
Exactly. So, you know, hopefully this session you've been able to kind of put those pieces together and trace it back to some of the previous material that you had prior. So, any other questions you folks have that you want to ask? Any burning questions? If not, then happy studying.
I do have a question.
Okay, go.
On this sulfa drug, for patients with Crohn's, that's like the primary go-to medication if they're not allergic to it. Right.
That's the primary one.
Is from the quiz, I wasn't 100% sure on like effective patient teaching if it was they need to wear an antibiotic or not antibiotic, sunblock if they go out into the sun like they would with an antibiotic.
Okay. If that is if that is one of the recommendations, then yes. So they should be in sunblock. I want to say I mentioned that in the lecture too. I'm trying to find it just to make sure I don't misquote it. Hold on.
You mentioned that you would take it with a corticosteroid, but you didn't say anything about a sunblock.
Mm-mm.
Okay. So yes, they'll give them the sulfamed or drug, and then why are we giving them the corticosteroid? Let me just go ahead and ask and see if you remember.
If that drug is not working by itself?
If it's not working by itself, but also to decrease the what?
The symptoms.
And is this corticosteroid short or long term?
Short.
It's
Short term. So, hold on, somebody's chatting in. Do we cleanse bowel if perforated in bowel obstruction? They're going to actually cleanse the peritoneum. So they're going to go in and flush all that stuff out and stitch it back, or do a resection is what they're going to do. Does that answer your question? That came from Sarah. Okay, great. So yes, they have to have surgery once the bowel perforates. So once that means all the poo that was inside the intestines is now in the peritoneum, and that cannot stay there. That person's going to have a ravenous infection and they'll become septic and die. So we don't want to do that. But make sure you know your signs and symptoms related to Crohn's, the diarrhea, weight loss, bloating. Those were your main signs and symptoms. Your first line for your mild cases, if they're not allergic, is going to be the sulfasalazine. So that's an anti-inflammatory. And if that doesn't work, then they will add in a corticosteroid. They have others that they can use, which was the TNF, the tumor necrosis factor. They also have Imuran, Humira. So they have several different ones that they can use, but they're going to start with the sulfa drugs first.
I saw a commercial yesterday, and it was for Humira.
Mm-hmm.
And so it gave a couple of patient education tips about no live vaccines, and it increases your risk for infection. So if you've been exposed to TB and
see,
so.
But they have a new one, and I'm so sorry that I didn't bring it up. It's called Envytivo, Envytivo. I wrote it on the board, but it's a new Crohn's medicine that was on TV it was on that morning right before lecture. I was like, wow, isn't that something? So they're trying to, before they were kind of limited as to what they can do, but now they're developing more or trying to develop more effective meds to help treat Crohn's. So there's no ulcerative colitis, but even though I did kind of give you the difference between the two, Crohn's is from the rooter to the tutor, right? And ulcerative colitis is mainly your large intestines. So should we give them NSAIDs?
No.
Nope, because that damages the GI lining. So that's why we don't do that. They may need antibiotics, and they usually get Cipro if they're going to get it. And this is for Crohn's. We can do bowel resection, but it's hard because of the fact that you can have the cobblestone appearance. You may have healthy tissue, then diseased tissue, diseased tissue, diseased tissue, healthy tissue, disease, and then whatever's healthy can become diseased. Right? Remember that?
Yes.
Okay. All right, guys. Any other questions? I think you got this. And then you have your HESI study guide, and you can use that study guide for both comprehensive and HESI, because it basically covers all of your exemplars.
Thank you.
All right.
Thank you.
All right. Well, enjoy the rest of your Saturday evening and stay warm. And we'll see you Monday. All right, guys. Enjoy your weekend.
Thank you.
Thank
Bye-bye.
you.
Okay. Bye-bye.